Hello, everyone, and thank you so much for joining us today for Coffee Talks. Moderating today's event, we have Jonathan Ntombeni, one of our newborn business development managers. We also have Carissa Little, our newborn account manager, and myself, Kiabat Santos, also a business development manager. So passing it off to Jonathan, if you can share with us a little bit about what is Coffee Talks.
Sure, Kiabat. So Coffee Talks is something that we do once a quarter, and we just get together and talk about contemporary issues in newborn toxicology. Today's topic, fetal alcohol spectrum disorder, is something that frankly is just not talked about enough. And I am absolutely thrilled to have the panelists that we have together with us here today. We have Dr. Aileen Baldwin and Dr. Elizabeth Welch-Carre, who will be sharing with us a lot of great information. So Liz, Aileen, I'm just going to ask you guys if you would take a few moments and introduce yourselves. Just tell us a little bit about your background and what you do today. Aileen, let's start with you.
Hello, everyone. My name is Aileen Baldwin, and I am the Assistant Laboratory Director for Research here with USDTL. In my position, I use the biomarkers that have been developed in our lab in order to promote our external research program. So I've been the lead investigator on multiple collaborative studies with universities, hospitals, and public health programs around the United States as well as abroad. Much of my research expands on our work with identifying maternal drinking during pregnancy and also screening for prenatal alcohol exposure in newborns, and then identifying the developmental consequences in young children.
Thank you so much, Aileen. Liz, I'm just going to ask you to do the same if you don't mind.
So my name is Liz Welch-Carre. I am a neonatal nurse practitioner, and I will apologize. I have to work off my computer like this. So if you see cats flying around or fighting, I can't stop it. So in any event, I have been a neonatal nurse practitioner for 15 years now. I am also the adoptive mother of a child with fetal alcohol spectrum disorder. So this has sort of become a big focus of mine. Substance use disorder has always been a focus of mine. But then when you have a child who has a disability, you can become sort of consumed with the topic. And so that's what happened to me.
Thank you so much, Liz. We need to do a little bit of housekeeping. Crystal, will you just kind of lay down the format for us today?
Yes, absolutely, Jonathan. Thanks, ladies, again for that great introduction. So let's get started with the housekeeping rules. Please submit any questions that you may have into the Q&A section at any time during the session. At the end of the session, we will open up the platform to answer any questions that you may have submitted. Now, I know that it is a lot of information that will be given today, so we'll be sending a recording to all attendees to view for future use. We'll be also sending copies of the articles mentioned in PDF format as well. Now that we're done, let's jump right into our discussion with our guest speakers. So Aileen, would you start by talking to us about what fetal alcohol spectrum disorder is, which is known by the abbreviation FASD?
Sure. So fetal alcohol spectrum disorders is actually an umbrella term for all of the conditions that can occur when a mother drinks during her pregnancy. So these can include the physical, behavioral, and learning problems that the child might have. The most severe outcome from chronic exposure to high levels of alcohol during pregnancy is a diagnosis that's known as fetal alcohol syndrome, or FAS, which is defined by growth deficiencies and specific facial and nervous system malformations. Alcohol-related neurodevelopmental disorder, which is known as ARND, is another diagnosis that involves intellectual disabilities and problems with the child's behavior and learning. A child that was exposed in utero might also be diagnosed with an alcohol-related birth defect, which is known as ARBD, which involves problems with the heart, kidneys, bones, or with hearing. So while there are multiple different conditions that an alcohol-exposed child could have, the term FASD is used to incorporate all of these different conditions.
Aileen, thank you for that comprehensive overview. Liz, I've heard it said that a glass of wine before bed is not a big deal during pregnancy. And I want to say I've heard one of my NP professors say that moderate alcohol consumption is not a significant concern beyond the first trimester. How would you respond to that? And why should drinking during pregnancy be a public health issue of concern?
So this is what I would say. So we know from study out of Denmark that fairly low amounts of alcohol to just moderate amounts early in the first trimester can cause fetal alcohol syndrome or partial fetal alcohol spectrum disorder. In fact, children are exposed to 1 to 4 drinks per week were 8.5 times more likely to present with fetal alcohol syndrome or partial FASD. The study that was done only looked at kids who were just 5 and under. So you can't really know what the long-term implications are for their brain. So then there was another study that was out of Australia that showed that kids who'd been exposed to even low-level alcohol in utero, so 1 to 2 drinks per occasion, or at the max of 6 drinks per week. And in that study, the average number of drinks in a pregnancy was 27. And those kids had a greater incidence of depression and being withdrawn. And they were beyond 5 years old. These were older kids. So, and we know that we all know that the brain continues to develop until young adulthood. We talk about it all the time. Your brain doesn't reach maturity until sometime between like 21 and 25. And the other piece of all this is that research has shown that exposure to alcohol in utero can cause premature cell death. And when you have premature cell death, that impacts next lines of neural cells. So that early cell death will affect plasticity of the brain, which is, frankly, we talk about plasticity all the time in neonatal intensive care, and it affects wiring in the brain. So, and the alcohol can impact the migration of cortical neurons, which also impacts the wiring. So in the first part of the pregnancy, you may see fetal alcohol syndrome, but because the brain continues to develop, then you're talking about, okay, now we're talking about FASD or alcohol-related neurodevelopmental disorders, because the brain, it doesn't stop developing.
Thank you so much for that overview, Liz. Aileen, this one's for you. One of the most important and often talked about developmental disorders is autism. According to a study published in the Morbidity and Mortality Weekly Report on the CDC website, for 2016 across all 11 sites, autism spectrum disorder prevalence was at 1.85%. How does that compare to recent studies on the prevalence of FASD?
Yeah, so the most recent studies that looked at the prevalence rates of FAS and FASD was using multiple sites in the United States, and these were done in school-aged children. As Liz mentioned, sometimes you don't see some of the deficits of FASD until the children, are above 5 years of age. So this most recent study was conducted in 4 communities, the Rocky Mountains, the Midwest, the Southeast, and the Pacific Southwest. And what they found, looking at the 4 domains that are known to contribute to fetal alcohol spectrum disorder, the dysmorphic features, the physical growth, the neurobehavioral development, and prenatal alcohol exposure, they found that the prevalence of all levels within the continuum of FASD, even using the most conservative estimates, was between 2 to 5% of the school children. And when they used a weighted approach, the estimate is as high as 9.8% of the children screened. So as you mentioned, in comparison to the study that found roughly 1.9% of children have an autism spectrum disorder, the rates of FASD in children can be up to 5 times that estimate. So from these studies, it's pretty clear, and I think they have basically confirmed that prenatal alcohol exposure is the most preventable source of birth defects currently in the United States.
Oh, thank you so much, Eileen, for that great information. So Eileen, this question is for you as well. I know that you were doing your own research on FASD. In your recent study published in Pediatric Research, you looked at the prevalence of prenatal alcohol exposure in a particular demographic. The scope of the study and what were those findings?
Yeah, thank you. So we here at USDTL have done a number of different research projects in collaboration with the West Virginia Perinatal Partnership. So this is an organization that is centered on a goal of improving health outcomes for pregnant women and their babies in West Virginia. And we have also worked with the Charleston Area Medical Center Women and Children's Hospital. So in recent years, West Virginia has been particularly affected by the opioid crisis. And in turn, they've seen rising numbers of polysubstance exposed newborns and also increases in the cases of neonatal abstinence syndrome. So in a previous study that we did, we conducted multiple hospital sites across West Virginia, and we found that 19%, or 1 in 5 of the babies, had evidence of drug or alcohol exposure. For this particular study, we wanted to address just the prevalence of prenatal alcohol exposure, and we wanted to do it at the level of the entire state. So we were able to partner with some colleagues at the West Virginia University, also the Office of Maternal and Child Health within the West Virginia Department of Health and Human Resources. And we were also able to get 1,830 residual newborn dried blood spot screening cards that had been collected from the entire state during a 3-month period. And our lab analyzed those dried blood spots for an alcohol biomarker known as phosphatidylethanol. Overall, we found that the prevalence of late pregnancy prenatal alcohol exposure across the state was 8.1%. And if you looked at the different regions across the state, these prevalence levels ranged from 2.3 all the way up to 17.1%. These are the regions that are shown in the figure that you guys see here that was used for the cover of the Journal of Pediatric Research in August of this year. And these prevalence rates are much higher than what had previously been shown in the state. And it's really provided great evidence to support and inform not only public health workers, but also policymakers and clinicians so that they can develop and promote effective prevention strategies to lower prenatal alcohol exposure prevalence across the state and really provide targeted interventions and treatment services for infants that are affected. Additionally, we looked at different maternal and newborn factors that were associated with prenatal alcohol exposure. So if you want to delve into that further, I believe the open access link to the article will be included following this talk.
Thanks, Aileen. Wow. I mean, the numbers are just so, eye-opening. Liz, we're going to put another study up, and according to this study that was published in JAMA, the weighted prevalence estimates for fetal alcohol spectrum, meaning if they took into account the sampling schemes and using data restricted to children who received a full evaluation, those prevalence estimates would range from about 3.11% to 9.85%. Now, Eileen's study, what we just heard, which looked at specific populations, corroborates this data, as does a 2013 study by Lang, which showed an increased prevalence among children in child welfare. Those numbers estimated a rate of 16.9%. So this is a very significant public health problem. We hear a lot, Liz, about autism spectrum disorder in the news, but why do you think we don't talk about fetal alcohol spectrum disorder as much, even though the problem seems to be so great?
So I think it's sort of a complex answer. First, we are diagnosing autism more frequently than we used to. I think some of that is that we've become clearer about the diagnostic criteria on that. The hard part with fetal alcohol spectrum disorder is that oftentimes it's an invisible disability. If a child doesn't absolutely have the face of fetal alcohol syndrome, then you're relying on making a diagnosis based on behaviors. And and frequently the significance of that doesn't become apparent until a kid is older or in middle school or high school and they're really struggling. And so their behavior the behavior of a kid with FASD is frequently written off as just being bad behavior. You have ADHD, so we'll medicate you for that, or you have disruptive mood dysregulation disorder. And so rather than figuring out that the kid was necessarily exposed, and because some of these kids, of course, are in the foster care system, they'll just have a diagnosis applied to them that isn't necessarily, their diagnosis isn't necessarily related to just having been born with ADHD. They will actually have FASD, and that's what's causing the problem. And then, of course, it can be complicated by if you have kids who've been living in foster care homes, that they may have moved from home to home to home, or they may be raised in chaotic environments. And so those things can contribute as well to making it harder to diagnose, because you don't know what the contributing factor is. And I will say that for my ex-husband and me, with regards to my daughter, we had to spend a lot of time having discussions with the school system about how to help them understand the needs of our daughter. It just, in really many ways for school systems, it isn't a part of their repertoire. And we also had to take our daughter to a very specialized group in order to get her diagnosed. She initially saw a developmental pediatrician who just said, oh, that's just sort of her nature. Although when you have a 2-year-old who's screaming at the top of their lungs and trying to, punch through a door, I have to say, I have 4 other kids. That was pretty unusual behavior. In any event, so I just think some of it is just so difficult to diagnose because without the features of the face, you're oftentimes just sort of shooting in the dark.
Thank you so much for that, Liz. We've sat in quite a few workshops on FASD, and studies have found that among youth with FASD, a large majority of them had never been previously diagnosed or had actually been misdiagnosed with another condition. As a provider on the front lines, would you say that early identification of a possible FASD is important? And if so, why?
So I think one of the key pieces with FASD is that those kids are usually neurologically atypical. And I think with any kid who is neurologically atypical, it's very helpful to know that early in life, because if you do, then you can start providing resources to the family. And so, for example, if you know early, it can modify how you are as a parent. As a parent, you can become very frustrated with bad behavior, and you try to change that, as opposed to, for example, just reinforcing good behavior, like they recommend you do with your dog. And I don't mean that in any bad way with regards to humans, but it really does make a difference if you spend more time focusing on the positive than the negative. If you know early on, it can help have discussions with teachers about how they can engage with kids with FASD to make it more likely that they will be successful. And when kids with FASD are struggling in school because they often are lacking impulse control, their response to it is just to become angry or say this is stupid or I don't want to do this. And so they can get a reputation for being obstinate, for being lazy, for not caring. And that's not what the reality is. It's that they truly don't understand. And they often can seem like they understand, like one day they'll understand and the next day they won't understand. And as a teacher or as a parent, that can become frustrating. And so when one recognizes that that's due to the disability, I think it helps maintain for the adult to sort of understand it's got nothing to do with you. And it's not that your kid is just trying to annoy you. It's that it truly is a difference in their brain.
Liz, I'm going to stay with you for a second. What I'm hearing is that, getting an accurate patient history is so important when evaluating for a possible FASD. And of course, it's very difficult to do after the baby has grown up and might be presenting with behavioral or developmental concerns to a pediatrician or psychiatrist. Well, I've had some candid conversations with doctors who will admit it can be difficult to have this dialogue about substance use during pregnancy, especially when they're trying to build up that patient-provider bond and relationship. So how do you approach these conversations, and what bits of advice would you give to other providers?
So I have to be honest that, I just spent a year so I'm a neonatal nurse practitioner. I just spent a year in a psych mental health nurse practitioner program. And there are a couple of things that occurred to me after just doing a year of the program. And that is, in the neonatal world, we need to do a better job about asking parents about mental health disorders within the context of their families. Because if we do that, sometimes we can get some history that there was substance abuse in the family, that there was depression in the family, there's bipolar in the family, et cetera, so that we can be prepared for what's going forward for these parents. And so within the context of that, then once you've sort of gotten a little bit of history about the family, then you can have a discussion with the mother about her history. There's no question that an individual needs to be very comfortable having these discussions. In the same way, that nurses have to learn how to have conversations with with families or adults after they've had surgery that may, for example, impact their sexual life. And we all can get worked up and uncomfortable about stuff, but in the end, you have to be able to have the conversations. So for me, I often will be asked about, what medications were you taking during your pregnancy? Can you tell me what they were? Can you tell me what the dosages were and the frequency of that? And I want to know what you've taken in the past. Have you been on antidepressants in the past? Because that can give me some indications as to whether, if you're not on them anymore, what's your risk for depression? Was there any risk that you might have been self-medicating during your pregnancy? And then, from there, I go into asking about whether an individual is using any legal or illegal drugs. How often were they drinking alcohol and how much during their pregnancy? How many cigarettes did you smoke, per day? In general, you do better if you ask a question about how much, as opposed to saying, did you drink, did you smoke? Yes and no answers don't get you the information that you need. And I try to be very frank with families and let them know that I'm seeking information, but my goal is not to judge, because what is done is done. My goal is to offer the opportunity for the best outcomes for their child, because I know that that's what every family wants for their child as well. And as I said, I explained that there isn't any way to change what happened previously during the pregnancy, but we have the potential, if we're providing resources and support and services to the child, that we can change the future for that child. And I think that's an important part to share with families. Most women who drink during pregnancy, studies are showing that they had adverse childhood events, such as child abuse. And so that may well be contributing to their substance use disorder, or the fact that they're drinking during their pregnancy at all. And some women don't know what the impact of alcohol is, because we're not saying, okay, if you have, 4 drinks in a week, that may absolutely have an impact on your child. And some women are struggling with substance use disorder, and it's hard to stop. And substance use disorder is a very complex disease. So I just always try to approach it with best intent for the family and for the baby.
Thank you so much, Liz, for that great insight. And I totally agree with all of the information and advice. As far as giving advice to other providers that they're trying to help the community with the safety of newborns, similar to USDTL's mission, which is to protect and enrich others' lives. Aileen, part of what we do here at USDTL is to test for the presence of alcohol biomarkers. Can you describe the difference between ETG, FAEE, and PEth testing on the newborns? And what do you think are the best benefits of each test?
Yeah, sure. So when a woman drinks alcohol while she's pregnant, the alcohol can pass from her blood and also into the fetus through the placenta and umbilical cord. And it's then in the fetus's blood and in the amniotic fluid within the placenta. So while the fetus can actually metabolize the alcohol, the rate is somewhat slower because the fetus has a reduced metabolic capacity. So as the alcohol is metabolized, there are different metabolites that are formed. And these are the biological markers, which we call biomarkers, that we look for in different newborn samples. So as you mentioned, ETG is ethyl glucuronide, as it is an alcohol metabolite that's formed by methanol, and it can be detected in meconium, placenta, and umbilical cord tissue. So in our laboratory, we use the umbilical cord samples that are collected at birth to identify ETG. FAEEs are the fatty acid ethyl esters, and those are also metabolites of alcohol, and they can be detected in umbilical cord tissue, blood, hair, and the meconium of newborns. So our laboratory identifies FAEEs in the meconium, which is the first stool sample that the baby has following birth. PETH, as you mentioned, is phosphatidylethanol, and that is actually a unique phospholipid that is formed from a reaction when phosphatidylcholine in the red blood cell membrane comes into contact with ethanol in the blood. So all of these biomarkers have different benefits. Looking at ETG and umbilical cord and FAEEs and meconium provides a nice long 3-month look back window. But in my particular studies, I've found that the benefits of using the PETH in newborn blood spot cards make it a more valuable tool to screen for prenatal alcohol exposure. For one, the collection of newborn screening cards at birth has been a routine practice for over 50 years. It also makes for easier sample collection. In my most recent study, when I told the nurses that they wouldn't have to be collecting meconium samples, I think they jumped for joy because the newborn screening cards are so much easier for them to both collect, also transport. They don't need to be shipped on dry ice and stored. We've shown that PETH is stable at room temperature for up to 6 months. And also in both our studies and also our colleagues' studies, we've all found in different populations that PETH is just more sensitive in its ability to identify prenatal alcohol exposure than if we were to use ETG and umbilical cord or FAEEs in meconium.
Thank you so much, Aileen, for that great information on our test and differentiating them both. Liz, so one question neonatologists need to answer is, why am I ordering this test? How could having this data point in a child's medical history benefit their care both short-term and long-term?
So having documentation of alcohol exposure in utero makes it significantly easier to diagnose an individual with fetal alcohol spectrum disorder than it is if you don't have that information. Now, it's not to say that the diagnosis can't be done without it. And today, some of the diagnostics that have been done have used computer imaging to look at individuals' faces to see if there are any of the abnormalities to the face that are typical of fetal alcohol syndrome. But that documentation of alcohol exposure frankly makes all the difference in the world. And when my daughter got diagnosed, I knew she had alcohol exposure because she was through the foster system and she was a patient where I was working. And so I knew her history. And so it made it easier for us when we were getting her diagnosed for that piece to be included in the diagnostic criteria. It is one of the pieces of the diagnostic criteria. So without it, it's just much harder.
Thanks for that, Liz. Liz, this one is for you. Since we met you, you have a rather unique perspective on this topic, and you're just so passionate. Not only are you a neonatal nurse practitioner who specializes in infant exposure to alcohol and other substances in utero, but you opened your home to the foster system and became a mom who raised a child with FASD. Can you talk to us about the impact FASD has on the affected individual, on the family, on the community, and what can be done to help provide best outcomes for everyone involved?
So I'll start with the end of the question. And I think with regards to providing best outcomes, I think early diagnosis helps. And I think then education for the community makes a big difference. And I'll get to that in just a second. The place where from my personal experience and knowing other individuals who have kids with FASD is the most difficult piece is the sort of lack of executive functioning. The place where the alcohol affects the brain the most is in the prefrontal frontal lobe of the brain. And so, you know, lack of executive functioning does, it can contribute to things like ADHD. It can contribute to impulse control. It contributes to sort of being able to understand how to get through life as an adult. It's very difficult to plan for the future if you don't have any impulse control with regards to that you need to save money, or you need to have money in your bank account to pay for your car payment or for your rent, et cetera. And the other thing that can be problematic is the lack of understanding of consequences. So, so for kids who, for example, have FASD, you know, the typical ways that we might try to modify our kids' behavior, like, for example, with my kids, if, you know, if one of the kids got in trouble, okay, well, we're going to take your cell phone away. If you're not, you know, if you're not doing your schoolwork, we'll take your cell phone away. Those things didn't work with my daughter at all, because you know, if you do this, then this will happen. If you don't pay your rent, then you risk eviction. If you don't pay for your car, then you risk losing it. Those things just are not clearly understood. And so it's that. So and for example, when we're talking about my daughter, we often refer to ourselves as being the external brain, that, you know, we're on the outside of her, trying to get her to get to a place where, you know, we're guiding her towards these are the consequences if you do X. And then the quality, so for families, the quality of life can be affected if resources are not available. And the behavioral problems can be very difficult for families to manage. The outbursts, the yelling and the screaming and the temper tantrums and the involvement with the law, and, you know, they're exhausting, they can be expensive, and families can become incredibly frustrated, as can kids, because they know that their brain isn't typical. It's not like they're walking around thinking, oh, I'm typical. They know that they're not typical, but they don't understand why. And I will say with my daughter, she knows she has FASD, which I think has been helpful for her to understand. And what's interesting is that they did discover that families who have kids with FAS, so with the syndrome in the face, so you can see it on the child's face, they have higher quality of life in general because people can see it in their child's face. And so the expectations for that child are not the same as they are for a kid who looks completely normal, but they are not behaving in what one would consider a typical fashion. And as I'd mentioned earlier, individuals with FASD are more likely to be involved with the justice system. Here in Colorado, there is a court in Denver that works specifically with individuals who have FASD to try to keep them from cycling in and out of the court system. But that's only in one of the court systems here in Colorado. And unfortunately, you know, my daughter is involved with the justice system. We were not involved with that court system. I think that, again, as I said, broader education about FASD can help with the outcomes. Education for teachers, education for police officers when they're approaching individuals with FASD, because again, these individuals can have outbursts. They're not necessarily dangerous outbursts, they may be, but it's also that they are responding in fear, they're responding with anxiety. Training for first responders, training for the judicial system. The American Bar Association has actually written that FASD is a disability that should be acknowledged in the court system. Education for healthcare providers, and, you know, anyone who has involvement with individuals who have FASD, it's very helpful for them to understand the implications of it. And we need to continue to remind women that to date, we do not have an identified safe level of alcohol intake while they're pregnant. So our recommendation is that they abstain. We're trying to figure out ways to address FASD post-delivery. And one of those ways is with nutrition to address oxidative stress on the brain, but we haven't figured all that out yet. So again, not drinking during pregnancy is our recommendation at this time.
Talking here and I'm muted, sorry. Liz, Aileen, thank you both so much. We really want to recognize the fact that this was a sacrifice for you guys to take this time and be here with us, and we are so grateful for that. We know you both have full-time work responsibilities and a ton of other stuff going on. In fact, you guys would never know, but Liz is coming off a 24-hour shift, and she's still committed to spend this time with us. So we're so grateful for that. We just want to take a few minutes now and allow the attendees an opportunity to, ask questions to our panelists today. If you'd like, there's a Q&A panel that you can open, and you can direct your question to any panelist that you would like to. So if you haven't done so already and would like to, now's the time to do that. But I'd just like to open that up to the panelists. And if you have some questions that you can address for us, please go ahead and hop in.
Yes, so there's several. So Aileen, there's several questions here, and so I'm gonna quick sort of run through them, and you and I can decide who was. So one of the questions is whether or not individuals are getting CEs, and my understanding is that there will be a certificate that's following this. Is that correct, Jonathan?
Yes, indeed. We will be providing a certificate of participation.
Okay. Then there was a question about how are we teasing out just alcohol use by pregnant women, which I responded in the chat, but I can respond here. To be honest with you, it's very difficult to tease out whether women are just using alcohol. And the other interesting thing is that I think that there have been disabilities, for example, with moms who, for example, may have been using opiates, or moms who are using cocaine, et cetera, that are being attributed to those drugs because we haven't actually gotten a history on the alcohol use. So we don't really know what is the primary contributor. If we are doing tox screens, so if you're doing the meconium, if you're doing the cord, you can get an idea about what other drugs may or may not have been used during the pregnancy. So I do think that's one benefit to getting the testing done, is not just so you know about the alcohol, but so you also know if there were other drugs, they may have been legal or illegal that might have been used during the pregnancy, and that can provide you with some more information.
Yeah, so with my current research cohort, we're actually doing a urine screen at multiple points during the pregnancy that does look at multiple drugs of exposure, and then doing a urine screen at the time of birth, and then also collecting the umbilical cord sample to do a full drug panel, and then collecting umbilical cord blood and heel stick blood on the filter paper cards to assess alcohol use. So it is possible to tease out. I do have a number of alcohol exposed newborns in my study that also had exposure to opiates, methamphetamine, amphetamine. So yeah, but using the different tests, you can tease out whether there's polysubstance exposure and also alcohol exposure on board.
So then there's a question about, someone said here that their agency sets up multidisciplinary groups in communities across the nation to help address the issues around the impact of substance misuse and the impact it has on children, including alcohol. And they wondered if we had any information about the Native American population and statistics and information with regards to FASD and substance use disorder within that community. I can tell you that the data is out there. I've looked at it. Do I have it off the top of my head? I don't. I could certainly find it, and maybe Aileen has that information as well. But it's out there, and there's quite a bit of analysis on that. I will tell you, interestingly enough, the country with the highest incidence of FASD in the world is South Africa. And there's a long history behind that. And so a lot of research has come out of South Africa. But yes, that information is available.
Yeah, so Phil May, the researcher who did the JAMA study, he really started in New Mexico looking at Indian communities, Native Americans. And I believe one of the 4 sites that he used for that JAMA study was in a Native American county. And so Tim, and also a researcher, Ludmila Bakareva at the University of New Mexico, she's done a lot of studies in New Mexico also. So those would be 2 probably of the best FASD researchers to look up.
Okay, so a question here is about how old was my daughter when she was diagnosed? She was diagnosed, I want to say around the age of 4. And even though we knew she'd had alcohol exposure, I have to say it still came as a shock. And interestingly enough, so she has sentinel features of fetal alcohol syndrome. So I want to say she ranked as a 3 on the facial characteristics of fetal alcohol syndrome, but she has FASD because she didn't have a growth deficiency. She's actually taller than I am. She's 5'10", and she has pretty normal intelligence. She just has a lot of learning disabilities. How is my daughter doing now? My daughter has a full-time job. She's 21. She lives with her dad. Currently, she's not involved with the judicial system, which I'm forever grateful for. And I want to preface this with saying that my daughter has never done anything horrific. It's just that sometimes kids who are, again, if you have impulse control issues, you rise sometimes to the level of police having to look at you. And then there's a question here about what medications work best for FASD. We have not entirely figured that out. Kids who have FASD may well have to be treated with stimulants for attention deficit disorder. They sometimes are treated with atypical antipsychotics for impulse control, like for example risperidone. And there's mixed feelings about doing that with kids who have fetal alcohol spectrum disorder. Behavioral therapy can often work with them as well, cognitive behavioral therapy, because sometimes the medications don't work as well with them because their brain just it's wired differently due to the abnormality of what happened with the neurons as they were migrating in the brain. So medications don't always work quite as well with those kids as they do, for example, with kids who just, for example, have ADHD. For any kid who has a dysregulation issue, it can always be hard to medicate them. So I don't want to understate how difficult it is to treat mood disorders in children, whether it's due to alcohol exposure or for other reasons. Next question is, if someone is receiving OTPT and an IEP, what other services support are we referring to with regards to FASD? Some of the other services are just literally having people educated enough to understand what it means to have FASD. We had an IEP for our daughter, but we still had to spend a lot of time teaching teachers how to work with kids who have FASD. It's more than just, we're going to provide you with more time. It's also the way they engage with kids. It's also a willingness to explain things to kids 150 different ways, and then knowing you may need to explain it again 150 times the next day. So I don't know if that helps with that question, but it can be incredibly involved with regards to getting resources sometimes. Let's see, I'm running through all this. Training to diagnose FASD. Well, I can tell you, no, it takes, and Aileen share this as well. It takes years and years and years to get trained, and it's not a single individual. You'll have a developmental pediatrician, you'll have a psychiatrist, you'll have OT, you'll have PT, you'll have epidemiologist, you'll have a geneticist who understands dysmorphology. It's a huge team that has to do this sort of diagnostic testing. And that's one of the reasons why it's so hard to get diagnosed. It takes so many people. And I don't know if you want to add anything to that, Aileen.
Yeah, looking at FASD diagnosis takes, it takes a village, basically. It's not just one person, as Liz mentioned, there's multiple people. The next question was about how long it takes to get a PETH result back. Jonathan or Kiabeth, could you touch on the turnaround time?
When we're looking at PEth, it's an additional day outside of the norm for regular drugs. So you're looking at about 4 days approximately.
And current research is underway, specifically my study and studies done by Ludmilla to look at, what does a newborn PETH of 20, say about the mother's drinking rather than an 8 or a 50. There's definitely more studies on PETH levels and consumption in adults. A lot of the research being done looking at, veterans drinking, HIV medication benefits based on drinking patterns have used PETH. And so a lot of the data is coming out of adults, not pregnant women and not the newborns. But I have a current cohort that's looking at, maternal self-report, maternal urine, umbilical cord drug and alcohol screening, PETH screening at birth, and we're hoping to follow these kids so that we'll have a better understanding of, what PETH level, really predicts risk best for a child to, develop an FASD. We're just not there yet. But we do PETH testing at a very, low concentration. We can detect it down to 8 nanograms. And so it's really a powerful tool to show exposure. And I think the data will catch up with, exactly the different levels of exposure and the PETH.
So Eileen, do you want to answer that question about, they're asking about the newborn screen to confirm prenatal alcohol use? Do you see that question? I'll go back and answer the one previous to that if you.
Yeah, so the newborn screening of PETH, it will confirm that the mother was drinking, probably during the last month of her pregnancy. The other thing that we don't know is that we found that the PETH levels tend to be higher in the newborn if you compare a mother at birth directly to the newborn, which means that the metabolism of both the alcohol and the production and degradation of PETH in the fetus and the newborn is probably vastly different. I mean, you have to understand that this is a fetus versus, a grown woman. And so that is really something that we're looking into. What is the look back window for PETH and exactly how much have they been drinking? One of the problems that we've had in our studies is getting solid self-report data from the mother, because that's really what we need to be able to answer specifically your question of how much alcohol was she drinking to get, a PETH of 8 for the newborn.
And to tag on to that, with regards to what Eileen said, one of the difficulties also with the fetus is that, so the blood alcohol levels of a fetus can get to the same level as the mother. And of course, a fetus metabolizes alcohol differently than adults do, as mentioned. And then they pee. So the amniotic fluid can also have alcohol in it. And then they're, absorbing and swallowing the alcohol in the amniotic fluid. And then if a mother keeps drinking, they can actually get pretty high levels of blood alcohol. So it's a little more complicated when you're in the uterus, because you're sitting in sort of for lack of a better term, in a bathtub that's full of your own urine that has, metabolized alcohol in it that's not metabolized well enough. All right. So someone said, with regards to moms breastfeeding, are there risk factors for the infant if a mom drinks moderately? Absolutely. And actually, I just saw an article that was referencing postnatal alcohol exposure during breastfeeding, and it does have implications for the brain, because again, so early in life, your brain is producing neurons at a stratospheric level, and if you're drinking alcohol, if a mother is, and that baby is getting alcohol via the breast milk, that has, that can cause apoptosis or cell death in the neurons then as well, in the same way that does in adults. I mean, I don't know how many of you have had the opportunity to meet an adult who has encephalopathy related to the fact that they're an alcoholic. I mean, it impacts everybody's brain. And so exposure as a newborn, just in breast milk, also affects the brain. We don't know what the long-term implications are, in the same way that we have we have more understanding of the fetal exposure than we do of the postnatal breast milk exposure piece. And then someone asked regarding training, how can we train others to understand it better or react to these children differently, not diagnose them? but in particular law enforcement, child welfare, et cetera. Most states have it's called NoFast. So there's a national organization of fetal alcohol syndrome, and that's the national organization. And then most states have a chapter of that, for lack of a better term, in their state. And from that organization, usually you are able to get information about educating individuals and working with people who have FASD. And so I would say that would be the first place to reach out. Minnesota, they have MOFAST, so Minnesota Organization of Fetal Alcohol Syndrome. They are particularly on top of this. And the other piece of it is there's a lot of information that comes out of Canada. Canada's done an extraordinary job of looking at kids who've been exposed to alcohol in utero, much more so than we have in this country. So I would start with the National Organization of Fetal Alcohol Syndrome and look for information there. Let's see, and I think Aileen, this next one would be for you. What are some of the analytical challenges with measuring PETH?
I think it's a pretty straightforward protocol. It's a methanol extraction, and then it's run on a GC mass spec, tandem mass spec. So I mean, other than not having the instrumentation, I think it's a pretty straightforward method. And also, just to add on to what Liz was saying, I'm looking at one of my conference posters on the wall. There's a, as she mentioned, Canada's really on top of FASD research, and they have a biennial conference on fetal alcohol spectrum disorders. And it really brings together an entire, the international community. And so their website would probably be a good place to look up speakers if you're interested in learning more from some of the clinicians and epidemiologists that are studying this. I think they post most of the presentations on their website, so that's a good tool also.
So Jonathan, I think we've responded to all the questions here in the chat.
Wonderful. Okay, if there aren't any more questions, Beth, we're gonna turn it to you.
Absolutely. So wow, what a message we received today. Aileen and Liz, thank you so much for joining us today and delivering such an impactful message. There were some great takeaways. I would like to thank our audience for joining us. Please be on the lookout for today's event's recording, and I encourage you to please share the recording to continue to bring awareness to this topic at hand. And with that, everyone, I thank you so much for joining us. Have a great rest of your day, and how about us cheers to our next coffee talk.
Like and subscribe to our channel to receive notifications about new videos.